All right, welcome back, everyone. Next, we have a couple of guest speakers. So our first is Aidan here. So Aidan is an internationally recognised paramedic, educator, and now a junior doctor based in Sydney. He was Central Queensland University's Alumnus of the Year in 2022 for his contributions to paramedicine and emergency medicine internationally, and is also the recipient of a Phillips Young Clinical Pioneer Scholarship for his work developing pre-hospital point-of-care ultrasound. He holds appointments as an honorary researcher in urgent and emergency healthcare and workforce research at Kingston University, London, as a visiting lecturer in paramedicine and resuscitation at UK and Australian universities, and sits on the editorial board of the Journal of Paramedicine. Alongside his role as a junior doctor, how do you have time, mate? He's also the clinical lead for a CHS, a community emergency healthcare nonprofit, and is a non-executive director for EMUGS, our emergency medicine ultrasound groups of Australia and New Zealand. Aidan has lectured and taught in over 13 countries, and you can find him on Twitter at Aidan_Baron. And it's our very huge pleasure to welcome you today and hear your experience on a skill critical to retrieval medicine, how to give phone advice to junior clinicians. Thanks, Aidan.
Thank you, thank you so much for having me. It's really awesome to be here. I just want to start with a quick acknowledgement of country. So I want to acknowledge that we're in Darug lands today, and I want to acknowledge and thank their elders past and present, and any First Nations people in the room or listening to this. Thank you. This is a beautiful painting of the watering hole by our Auntie Edna Watson, and I actually found that there's the Darug Custodian Aboriginal Corporation is a local non-for-profit that sells Aboriginal art by local elders and artists. And they've got these awesome prints, so I'll pop a link on at the end, but if you're interested, there's quite affordable ones as well. It's a nice little thing to give as a gift or have in your home, or acknowledge the land that we're on with some local art by local artists. Quick thank you. It's exactly 10 years actually since I first spoke at a CGD, so it's really, really awesome to be here and to reflect on how far the organization's come since the old, slightly decrepit base that was sort of falling apart, and how far the organization's transformed, but also has the same heart and passion and cultural integrity. So I really appreciate the invitation to speak today. I don't, unfortunately, have any conflicts of interest, but I do want to especially thank two people. One is Elliot Williams, the new Assistant Director for Nursing Midwifery at New South Wales Ambulance, who was the executive sponsor for a lot of what I'll talk about today. And also to Nat May, who came and spent a lot of time helping us develop our teaching education modules around debriefing and feedback. This is not a talk about closed loop communication and some fancy acronyms on how to give feedback, but it is a talk about the lessons I've learned creating and developing our systems for giving advice over the phone. And I feel I'm somewhat uniquely qualified as someone who gives a lot of advice over the phone as a paramedic, but also someone who, as an intern, often calls late at night for a lot of advice now. And if you are the recipient of my poorly constructed referrals at night, I apologize. I guess the story sort of starts in 2019. I just come back from a year in the UK, and I started doing some volunteering with St. John in a sort of strategy role. And I have a particularly soft spot in my heart for volunteer organizations, because I feel that volunteer organizations are able to do things that we can't often do in the regular workforce. This is from the city to surf, and St. John Ambulance is able to put a team with defibs and oxygen and first aid kits every basically 400 meters on a 14-kilometer course. And if we tried to do that as a health workforce that was employed, we'd probably bankrupt the city to surf, and we wouldn't even find the people willing to do it, certainly not willing to start marshalling at 3 a.m. and finishing up at 6 p.m. that day, giving up their weekend. So I really love that volunteer organizations are able to do these special things, and also that they provide meaning and identity and resilience to communities. So St. John's a really cool organization. There's about 2,700 volunteers around New South Wales. And they provide first aid and event health coverage at events, at local fetes. And the majority of the volunteer workforce are made up of volunteer first responders. So bakers, bankers, lawyers, cooks, retirees, stay-at-home mums, stay-at-home dads who are also really passionate about serving their communities. And I love that. Most of you will probably remember around 2019, we kicked off a few years, and you've probably repressed these memories like I have, but we kicked off a few years of some inclement weather in New South Wales. Between the floods and the bushfires, there were a few hairy situations. And so St. John in 2019 alone deployed 402 volunteers to 33 evacuation centres, treating 1,500 patients over 23,000 hours of volunteer service, and that was just 2019. We then almost doubled that over the next few years. So you'd all be fairly familiar with the fact that we suffer from the tyranny of distance in New South Wales, and that is very much the case in first aid and event health as well. But what's interesting is in the late 2000s and teens, we started to realize that there was this shift occurring in the landscape of first aid and event healthcare. The patients were getting more complex, and the social expectations, the sort of social contract about what patients were expecting was also elevating quite a bit, and patients were expecting, and the community was expecting, an increased level of care. And when we look at what first responders are able to provide, so we've got people who are trained in like a Certificate 2, Certificate 3 level of basic emergency care. They're really good at doing CPR, giving EpiPens, giving asthma puffers for severe asthma, recognizing really obvious fast positive stroke, giving aspirin for chest pain. But there's an area of what I call acute occult illness where healthcare professionals really come to the fore. And so I've got sort of three little vignettes that I might run by you. One's an 82-year-old lady who came into a first aid tent at a local fair, and she was feeling a bit faint, and she has a BP of 108 on 60 and a history of hypertension. And she's on a calcium channel blocker, an ARB, and Frusi, done quite a high dose of furosemide. She's had a headache for the past few days, so she's been taking Nurofen all week. And now she's got a bit of dehydration and a blood pressure that's a lot lower than her normal. And she's feeling just not quite right. But her blood pressure and her vital signs are all between the flags. And as a first aider, there's nothing that's obviously wrong with this patient, whereas everyone in this room clearly recognizes the risk here. Or the 13-year-old boy who was sitting having lunch outside at one of the community sporting events, and he had a faint while he was sitting down. And everyone has sort of brought him into the first aid tent, and they go, oh, he's fine, he's just a bit dehydrated. And you start digging into the story, and it turns out that his auntie died when she was a teenager while swimming at the beach, and no one's really sure why she died, and it was a bit unexplained. Or the 52-year-old who came in and he is, do you have any Mylant or Gaviscon? I've just got really bad indigestion. I left it at home. I've normally got indigestion, but today's a bit worse and is a little bit sweaty. And you ask, do you have any medical problems? No, perfectly fine. When's the last time you saw a doctor? Oh, I went to the GP, a few weeks ago, and he did this test. It's like a CB calcium something, and he said it was really high or whatever. But so I've got to go see the cardiologist, but I'm sure it's fine. And these are all fairly concerning patients to us, and we all intuitively know that these patients present some significant risk, but it's beyond the level of what a first responder is trained to do. And that's where, as healthcare professionals, our professional education really comes to the fore. And there's a colleague of mine, Thomas Barry, who set up a lot of the community first responder schemes for cardiac arrest in Ireland. And as part of his doctoral studies, he looked at this liminal space between lay people and healthcare professionals and sort of the challenges that occur in giving advice, in governing, in teaching this group of people. And when giving phone advice to this group of people, I think a lot of those lessons are actually translatable to a lot of what we do on a regular basis, this area of sort of liminality, where the way we use language, the intended meanings it has, the way we understand risk is very different between these two groups. And even the way we prioritize and look at the big picture is quite different. And so communicating with people who sit in the middle, in that liminal space, means sometimes the words and language we use don't actually mean the same things. And the way we're looking at the picture is a bit different. So we realized we needed to do something. So in 2019, we did an organization-wide survey of St. John Ambulance. I was pretty stoked. We got 272 responses, which is almost bang on 10%, which in sort of social and healthcare research is an unreal result on a survey. And essentially, we got this breakdown of clinical roles in the organization responding, which was fairly representative for the emergency healthcare workers, non-health professionals, but probably a bit overrepresented of some of our health professionals in the organization. We only had 230 health professionals in the organization at that time. And what we found was, this will not be surprising at all, but we asked people, how often is a healthcare professional on duty with you when you're doing first aid at an event? Most of the time, some of the time, only on rare occasions, or never. And so almost half of our rural volunteers said that only on very rare occasions a health professional was on duty with them. And even in metro areas, only about a third of them had regular health professionals accompanying them on duty. And so I then asked another question, which I thought was really useful to us. It's, how well supported do you feel by the organization when you make a clinical decision? And this was sort of a real telltale culturally. 3 out of 5 on a Likert scale of 1 being really bad and 5 being pretty good. 3 out of 5 is not too bad in terms of Likert scales, but if it was an Uber rating, I wouldn't hop in that car. So we weren't stoked to find out that this was the case. Fortunately, things have improved a lot. What we then did is we cross-referenced this with healthcare professional accompaniment. And what we found was that if you look at a Likert scale of how well supported do you feel by the organization on a scale of 1 to 5, 1 being really bad, 5 being really good, and then you look at how often a healthcare professional's with you, there's a really strong, super statistically significant relationship between that. And that was our sort of aha moment of, we know what we can now do to start helping things. So we had an impetus to act. And what we decided to do was we decided to ask people, okay, if we designed a clinical advice line, how would you feel about that? And would you use it? And people were pretty keen on the idea of a clinical advice line. And so what we then did is we, in this survey, asked a bunch of open-ended questions and let people just tell us how they felt, would they use it, when would they use it, what they wanted, and what did they want us to do? How did they want us to make it look and feel? And to do that, we use this thing called framework analysis, which is this style of qualitative analysis that comes out of recursive thematic analysis, which is a whole bunch of philosophical me sitting at a table for hours and hours and hours, poring over what people said. And we got some really, really useful information from this, to the point where we actually completely restructured what we were going to do and how we were going to implement a clinical advice line across New South Wales. And it was a really nice temperature check on the organization's culture. And this is probably my favorite. And I'm really grateful to the volunteers who were so honest and candid and constructive in the feedback that they gave us and what they put into these anonymous survey forms. So we sat down, and using framework analysis, we pulled all these responses together, got 33 codes out of that, and came up with this statement. And I'd like to go out on a limb here, no pun intended for this afternoon's session. I'd like to suggest that you could probably replace the word volunteer health responder with literally any clinical role in healthcare, and you'd find a fairly similar statement. And that's also because this is the first ever research of its kind asking people who work in healthcare what they would like out of a phone advice system. And so there's a few concepts that we drew out of this. The first was, you'll notice in that statement, understands the limitations of being in the field. There's this concept of the brokerage of pragmatism, which is basically when someone calls you for advice, you've got the entirety of your medical knowledge and clinical training in your mind relative to this patient in front of you, but you have to contextualize it into what's available for the person treating the patient on the ground. And that means untangling what you've got and presenting them with a really clear, perhaps framed, packaged, and perfectly presented plan of what's achievable. Because it's incredibly frustrating when someone tells you to do something that you're not able to do. So it has to be translated to the context. And what it means is that we specifically selected clinical advisors to start with who had experience of being first responders before they were health professionals. Because it's actually really, really irritating and difficult when someone asks you over the phone, what's your scope of practice? If I tell you I'm a P1 paramedic, you should already know what that means and what I can and can't do. Because if I have to start explaining an entire page of clinical practice guidelines of what I can and can't do, it's just not feasible in the time, but also it's quite frustrating. I know as a junior doctor, when someone says over the phone, oh, can you please get bladder scans for that patient? And I go, that's great, I'm on a psych ward at the moment, there's no bladder scanner. I feel like I've let the patient down and it makes me feel bad, notwithstanding the fact that it's not good advice because I can't implement it. And so when we started breaking that down, part of what we included in our training is a few checks, things like, where are you? Who else is with you? What do you have available with you? And then after discussing a plan, we'd ask a specific question, which is, how comfortable do you feel doing this? Which is very different to, do you feel comfortable doing this? Because that's a leading question that essentially ends up in a yes or no answer. And if someone's in a vulnerable position calling a senior person for advice, they want to please me. And so they're going to say yes, even though the answer is actually, I'm not sure. Whereas, how comfortable do you feel doing this? And they answer, sort of. I go, okay, I'm actually going to make some of the triggers for escalating this a bit more conservative. The other thing which we started looking at is that terms have different meanings which aren't necessarily apparent to people outside of the disciplines that we work in. For example, everyone from hospital-based medicine who's now come to pre-hospital care will note that there's very value-laden terms which we never really appreciated before. You'll have definitely experienced this. And so plain language isn't what we're looking for, but safe language is definitely what we're trying to hit here. If I say senior review, this patient needs a senior review, it means completely different things in different contexts. And if I said to you, I wouldn't sit on this patient too long on scene, that means very different things to a lot of different people. So language which is direct and explicit and doesn't use jargon related to specialty disciplines is actually really key to patient safety in these contexts. And early on, we noticed that there was a lot of miscommunication and patients got not necessarily the most ideal plan because the advice that was given wasn't explicit and used jargon that we in hospital or pre-hospital care sometimes take for granted, because our advice line is staffed by experienced paramedics, experienced nurses, nurse practitioners, and physicians. So we sort of had our challenge cut out for us. There was a bit of a culture of mistrust and fear. There was a sense of, I don't want to get into trouble when I call for advice. There was, I don't want to look stupid. And so not only did we have to design a clinical advice line, but we actually realized we had to design a culturally and psychologically safe clinical advice line. And so we turned to my absolute favorite modern thinker. A lot of you will probably be very familiar with either him or his work. His name's Sidney Dekker. He's an organizational psychologist from Scandinavia. He's now based in Griffith in Queensland. You've probably heard of a lot of his work, things like Safety 2.0, Just Culture, Restorative Justice Cultures. He's done some fantastic writing and even better presentations. And I'll link to one of his talks at the end of this. And when he was brought in as one of the official investigators for the Deepwater Horizon offshore mining explosion, he said this, which I absolutely love. We must see safety not as the absence of negative events, but as the presence of capacities to make things go well. And I love that. I love that statement. And so when we sat down to design our clinical advice line, we brought our advisors in and they were expecting us to give them like a 300-page manual on how to give advice. We gave them a literal one piece of paper. This is your part of the manual. We trust you to give safe and reasonable advice. There was no point creating pages and pages of guidelines. We may as well just give that to the person calling for advice in the field. The point of an advice line is that someone's calling you, you need to engage your brain. And we needed to trust them to give good, safe, reasonable advice. And so that's what we did as an organization and indemnified them to do so. And then what we need to do is we need to make sure that the people calling for advice, the first responder calling, picking up the phone 3 hours from hospital in the middle of regional New South Wales, felt that they wouldn't get into trouble when they called for advice. And so what we did is we ring-fenced the pro-safety behavior of calling. We got the CEO and commissioner of the organization to agree to strict confidentiality on all recorded advice calls. And what that means is that no one can access the recordings from management. No one from investigations or clinical quality can access the clinical advice line recordings. You literally have to subpoena these recordings if you want to get access to them, because they cannot be used against people punitively or in investigations or to get people into trouble. And our rationale for that was that it was in the interest of greater patient safety that people felt safe to call and that they wouldn't get into trouble, rather than perhaps benefiting one or two patients in a bit of quality improvement by having access to recordings where people didn't feel safe. And then it came down to designing the infrastructure. And this is where things got really interesting. If you think of the head of Legal Aid Australia, she doesn't volunteer on her weekends at one of the pro bono legal services. And if you think of one of the professional lifeguards at Bondi, they don't volunteer on their days off to patrol the beach as a volunteer lifesaver. So why did we have healthcare professionals volunteering their time in a healthcare organization? And I was really curious about, why do people volunteer? And the hypothesis I came up with is that people volunteer because it offers them an opportunity to do something outside their daily life, which validates their self-construct. And so by understanding people's motivations for volunteering, we then designed the roles of a clinical advisor around what would derive the most meaning for people, maximize their pleasure, and minimize how much people felt it was like their work. And what we did is we created a clinical liaison officer role, where we reached out to all the student healthcare professionals in the organization and said, hey, would you like to come and join our unique, beautifully enculturated, sort of almost elite team? And what we're going to get you to do is we're going to get you to listen to all the advice calls and transcribe them. We're going to get you to follow up all the patients and call them back and find out what the outcomes are. And in turn, you're going to be developed by us, be part of our debriefs, and learn by listening to hundreds of advice calls, to the point where we'll eventually succession plan you into being great advisors after a few years of experience, because you've listened to more advice calls than literally anyone else. And you've learned what works and doesn't work. And what that means is we've got these brilliant student healthcare professionals who come in, they send out the rosters, they text me at the beginning of the week, what shifts are you available for? They plan everything, they do a lot of the follow-up, and they transcribe the calls. And it means that on a Saturday afternoon, on my day off, I get an advice line call, I pick up the phone, I do the advice, I put down the phone, and that's it. I don't have to do any paperwork, which I love because I hate paperwork. And we're offering volunteers value. And what we did is we essentially looked at how we can remove friction points. And this translates to a lot of what you can do in your daily practice and in your workplace, which is remove the friction points that are unnecessary for people, make their job more pleasurable, and increase the enjoyment in what we do. Find creative ways to offload things that you don't want to do. And then what we did is we broke down an advice call into essentially 3 technical aspects, which is the advice about treatment, what we suggest you do to this patient, escalation triggers, so what to look out for if this patient starts to have this symptom, you need to worry about this, and risk risk stratification or disposition advice, where this patient needs to go, which is pretty easy in pre-hospital care. There's only really 4 options for us. This is the easy bit though. The difficult bit is the assessment. And we know that from the literature on telehealth, and you all know that from your experience. Assessing someone over the phone is tricky. This is Plato's cave, the allegory of the man seeing shadows on the wall and thinking that was reality. And so the concept of the problem of objectivity is a real challenge. So we simulated, and we simmed heavily, and we talked through ideas that we could use in assisting us in assessing patients over the phone. You'll probably all be familiar with the textbook Evidence-Based Practice by Professor Tricia Greenhall. And if you aren't, you've definitely seen quotes from her scattered throughout the boring medical training you had to do on research and stats at some point. She's an absolute heavyweight of evidence-based medicine. She's at Oxford, and during COVID, she did a phenomenal study validating that the number of steps a patient can walk up at home is correlated very significantly with their degree of breathlessness and clinical status. And she used that as part of the NHS guide for GPs assessing COVID patients at home. It was a nice validated tool for phone assessment. And there's tens of validated tools out there that you can actually use over the phone. One of the ones I really like is Paul Savage, who wrote the RNLI handbook, which is the sort of life-saving UK handbook. He talks about all patients as being big sick or little sick, which is the same as Scott Weingart's looks like CRAP score of 0 or 1. It's a nice way of getting a sort of gestalt feeling from a fairly inexperienced clinician over the phone. Is this patient big sick or little sick? Tells me immediately what I'm working with. More importantly, though, we did a whole bunch of sim where we closed our eyes and tried to perceive what was happening in a simulation, and then opened our eyes and looked at how different things were. And it was really useful in rapidly appreciating how much we all needed to improve our communication and assessment skills. And we've really fine-tuned that. And you can do that yourself just by cognitively rehearsing what you might say over the phone and fine-tuning how you can perhaps get the best assessment out of someone by modifying your language.
It's not for you.
Good.
We'll start.
Excellent. So what we then did is we built an advice line cycle. And essentially what this means is we built a cycle of 360-degree feedback. What would happen is after my advice call, I hang up the phone. A few days later, one of our clinical liaison officers calls up the patient and goes, "Hey, what happened to you? Did your ankle end up being broken?" The patient goes, "Yeah." And they go, "How was our care? Do you have any feedback for us?" At the same time, they've also gone to the caller, the first responder, and gone, "Hey, what was your experience of calling us? And do you have any feedback for us?" And they've gone to me, the advisor, and gone, "Hey, how do you think that went? What do you think the diagnosis is? And what lessons can we learn from this call?" And then they pull the feedback from the patient and they hand it back to the person who called for advice and go, "Hey, well done on calling for advice, positive reinforcement of a pro-safety behavior. Just by the way, the patient ended up having a broken ankle and they were so appreciative of your care." And then they come back to me and they go, "Hey, Aidan, just by the way, you're right, the ankle was fractured." Another win for the Ottawa ankle rule. But also the person who called for advice had this feedback. And then after a few calls, I'm going to sit down and debrief that with another peer advisor. And one of the clinical liaison officers is going to be part of that discussion. And as well as that, we built in a second tier of advice that on any given day of the week, 24/7, 365, we have probably 5 to 6 clinical advisors with at least one consultant physician on as a senior tier of advisor at any given point in time, which means that if you had to pay and cost the system, we would probably run it between $13 to $16 million a year. Given that it is a volunteer advice line, we run on a budget of approximately $600 a month. And it was all about building trust in the team and trust in the volunteers who were calling us. And that word trust kept popping up again and again and again. And so I was interested, what is trust and what makes it up? And there's this great quote, and I'll link you the paper it comes from in the social sciences and philosophy. It's to trust is to make oneself vulnerable to exploitation by another's actions but instead to believe in the preference of that other person, not to disadvantage or harm you. And I really like that because it speaks so much to sort of what we do and why we feel that we can trust people, because I know that they're not going to take advantage of me. And essentially, it comes down to that vulnerability. And the thing is, we all work in a very complex ecosystem in healthcare. And you've probably heard the word social capital. Social capital is the net value of trust between individuals in a system. And social capital is kind of like a bank account. But unlike financial capital, human capital, infrastructure capital, you can make deposits in your social capital bank account when you do things for people and you create trust. But also when I make a withdrawal by making myself vulnerable to someone and providing them with an opportunity to prove that they're trustworthy, i.e., I ask someone for a favor and then they do it, even though I'm making a withdrawal and I'm cashing in, I'm actually also growing my social capital bank account. It's the only type of capital that gets bigger the more you put in and you take out, which was really cool. If you think about sort of organizational culture is like a house, social capital is the funding you use to build that house. And so the implementation of our clinical advice line was just as much a cultural intervention designed to increase social capital as it was a clinical intervention designed to improve patient safety. Because ultimately, we knew that no one would call us if they didn't trust us, in the same way that no one's going to call a retrieval service if they don't trust the clinicians who rock up to treat them with value, respect, and validate them and affirm them. And so clinical safety relies on psychological safety and trust. And so essentially, when we started doing our training for our advisors, what we did is we framed every call as an opportunity for a hyperacute cultural intervention. Because there's probably few regularly occurring moments in healthcare where someone makes themselves so vulnerable to another person as when they're calling for advice. And certainly, most people in this room can reflect on a time where they had a very negative experience asking for something over the phone from a senior clinician, and it almost ruins the end of your shift. And it destroys trust and destroys social capital and has an incredibly negative impact on culture. So the stakes are quite high, but on the flip side, what an amazing high yield opportunity. And I'd suggest that perhaps, the impact of a good advice call has the same effect on social capital as the impact of some of our best hyperacute interventional therapies in some of our thromboembolic emergencies for clinical outcomes. So my challenge to you would be not to miss the very narrow opportunity for hyperacute cultural intervention that phone advice presents you by being pragmatic, understanding the situation of the caller, using safe language that's explicit, that's direct, using objective tools for assessment, and validating the caller for engaging in a pro-safety behavior, even though they might not be doing a great job. Because the fact of the matter is they've recognized that they needed help and they've improved the care that that patient's receiving simply by calling you. And so these are a few things that I hope have been able to translate to helping you improve patient outcomes by increasing social capital. Thank you so much. And here's a link to a tweet with a bunch of links. And thanks again for having me. I hope you have a fantastic day.